5 sessions as per syllabuses for each subject. And we are planning to wind up by October half so that you can prepare it well for your exams coming in November. With this intention, we have started these series. And today we have got Dr. Divya Srinath in relation to the Prasudi classes. The first two classes of all the sessions will be free sessions. After that, it will be paid sessions. For more details, kindly contact Dr. Jasul. Today, we invite Dr. Divya Srinath, Madam, to convey the classes. Thank you so much. Ma'am, you can start the class.
Thank you, Dr. Gauri. A very good afternoon to one and all. Today's topic is diagnostic techniques and investigations in obstetrics and gynecology. Am I clear? Am I audible?
Yes,
Yeah,
ma'am.
Dr.
clear, doctor.
Gauri?
It's clear.
Okay.
You can
Yes,
continue.
yes.
Okay. The first and foremost step in diagnosis of a disease is a proper history taking. You had to take the case thoroughly, like what is the presenting complaint, is there any history related to it, which help you to make a differential diagnosis. For example, if a woman came to you complaining of oligomenorrhea means there is normal 28-day cycle, but this lady is having cycle length more than 35 days. So such a patient, their differential diagnosis can be either it may be due to PCOS or even due to thyroid dysfunction or even due to anemia. So with this differential diagnosis, you had to make a proper diagnosis. So this medical investigation supports your clinical diagnosis. So you can select some of the investigations like PCOS.
Dr. Divya.
Yes.
I, hello.
Hello, Dr. Jaswal Enduti.
Hello. Uh,
Voice break ആവുന്നുണ്ടോ? Hello, Dr. Jaswal. Hello, Dr. Gauri.
Doctor, you can continue.
Okay. So I'm telling about the differential diagnosis. So for a proper differential diagnosis, I think some echo is there. So proper differential diagnosis, you had to do tests like an ultrasonography to rule out PCOS, or even do a thyroid function test, or even an HB test, which help you to make a proper diagnosis or an accurate diagnosis. So the investigation, there are so many investigations, like it can be a biochemical investigation. Biochemical investigation means with the help of body fluids, that it can be either blood or urine, etc. Some investigations are done, like that of even anemia for anemia HB test, or hormone analysis like FSH, LH, or AMH, like that. Hormone test is done, or even tumor markers like CA125. All these comes under biochemical investigations. So these are investigations which are done in body fluids. Okay. Diagnostic techniques means the investigations which are done to, like with that of screening test, or even with imaging techniques, which are comes under this diagnostic techniques, or even the pulse, or even taking BP. All these comes under the diagnostic techniques. These diagnostic techniques can be either invasive or non-invasive. Invasive means there is some piercing of skin, tissues, etc. Non-invasive means diagnostic techniques like USG, etc. are non-invasive techniques. So, for easy understanding, I had classified these investigations mainly into the common investigation that we are using in obstetrics as well as gynecology. So, first, we will see what are the common investigations that we are doing in an obstetrics. So, the first and foremost test is a urine pregnancy test. Sometimes most of the patient came to you with a UPT test result, either UPT positive or negative. So urine pregnancy test, we all know, right? In this, beta HCG presence is evaluated. Either its presence or absence is evaluated. Like a sample of urine is taken, 2 or 3 drops is inserted into this portion. So if 2 lines appear, it means there is presence of beta HCG. That is human chorionic gonadotrophin is present in the sample of urine. So that UPT is mainly to assess the presence or not. So this is a quantitative test, serum beta HCG. That is in blood, we are trying to quantify, that is how much amount is present. So it's a quantitative test. In this, this beta HCG hormone secreted from the trophoblast. As you can see, this is the trophoblast, and this portion develops into the embryo. So this trophoblastic portion contribute to the formation of placenta. So from this trophoblastic cell, this HCG hormone is secreted and which is present in the maternal blood. So this hormone passes into the maternal blood. So we can evaluate this HCG, serum HCG in the maternal blood. Okay, this beta HCG is present almost 8 to 10 days after fertilization. So if suppose today is 23rd is a menstrual period of a first menstrual day of a lady. After 14 days, it may be her ovulation time. Then after the next month 23rd is her expected period, menstrual period. So before 4 or 5 days, you can see or you can assess the serum HCG in the maternal blood to assess the pregnancy or not. If you are doing a UPT, you can assess or you can see the presence of HCG in urine on the day of the expected menstrual period. But in serum HCG, you can assess it 2 or even 4 or 5 days before the expected menstrual period. You can see whether the lady is pregnant or not. So one more thing is that the HCG level increases. That is, it gets doubled in every 48 hours. And it reaches its peak at about 8 to 11 weeks. It reaches about 100 international units. After that, it declines slowly and later it maintains a particular limit. So if a serum HCG is greater than 25 is considered to be positive, that is pregnancy is positive. So if less than 5 means negative. So how this 5 unit is present in the blood? So normally our body produces beta HCG hormone in a traces amount, like from the pituitary gland or even from liver, a trace amount of HCG is normally produced in the body. So if a value greater than 25 is considered to be positive, pregnancy positive. We can also apply this serum HCG, especially in diagnosis of pregnancy, as we had already mentioned, and also in diagnosis of ectopic pregnancy. That if that serum beta HCG is positive and this value gets doubled in every 48 hours, then after that, then we are doing a USG evaluation. There is no gestational sac is seen inside the uterus. So this is a normal uterus and usually the embryo gets implanted here. When you are doing a USG, you can see a gestational sac here. So when you are doing a USG and a gestational sac is not visible, but the serum beta HCG value gets increased, like by say about 60 to 80%, it increases in every 48 hours. So there may be a possibility of ectopic pregnancy. Ectopic pregnancy means this usually it is implanted inside the uterus if the embryo is implanted outside the uterus. The most probable chance is on the fallopian tube or even on the ovary itself. Another application is on spontaneous abortion. So if the beta HCG level gets reduced by 30%, then we can understand there is a chance of abortion. There is a chance of spontaneous abortion is there. Another thing, even in hydrogen mole also, there is after the removal, after the abortion, we can assess this HCG for whether for complete evacuation of this hydrogen mole, we are using this HCG marker, not marker, the HCG serum HCG. And even in a non-pregnant woman, sometimes we can see there is a increased level of beta HCG. It is seen especially in certain ovarian tumor and also in male certain testicular tumor have an increased serum beta HCG level. So we can use the same test in different contexts. Okay. So now we will see, first we will go to uh, for a doctor for an investigation, then there will be a routine set of investigations to be done, or these are just screening tests. We are screening a patient to, we are seeing whether this particular patient is present in this high risk group or not. So these are the common routine investigations like this common blood test, HB blood grouping, and we also do a fasting blood sugar and also postpartum blood sugar to find whether this patient is already a diabetic or not. This lady is already diabetic or not. Another common function we do is a thyroid function test. So the normally thyroxine is essential for the normal development of the baby. So in the first trimester or in the first 3 months, the baby depends thyroxine from the mother. So mother's thyroxine function should be normal. Otherwise, we had to supplement it. So the thyroid function evaluation is important. Thyroid function, a thyroid hormone or thyroxine is essential for the proper brain development of the baby. Another is vitamin D. Vitamin D is now routinely done procedure test. Then HIV and hepatitis B. These investigations are mainly done because it can cause vertical transmission. That is, this infection can spread from the mother to the baby. So, if we are diagnosing it in the first trimester, if we are managing thoroughly, especially in the HIV in the first trimester, there is less than 25% chance for transmission of this HIV to the baby. And another common investigation test like torch infections. TO means toxoplasmosis, R rubella, C for cytomegalovirus, and H for herpes simplex. These are a common group of infection. These cause congenital anomaly to the baby. So and also they may cause the repeated pregnancy loss to the mother. So these had other common routine investigation to screen the high risk mother, and we had to give special care or special treatment for her condition. Another is urine routine. Here we assess the albumin, urine sugar, pulses, etc. If certain urinary infection is there, which can also ascend to the vagina and which also even spread to the uterus also. And certain antenatal screening like weight. The weight of the mother is checked in every visit. Like the mother had to gain almost 10 to 15 kilos. This normal weight gain is essential for the normal weight gain of the baby also. So we are also checking this weight gain also. If a sudden weight gain along with edema, etc., and also if there's an increase in BP, then it may point to the pregnancy induced hypertension. So a proper routine weight checkup as well as blood pressure measurement is done as a routine procedure or as a screening procedure. So another examination is a biophysical examination, that we are assessing how the baby is, how the environment of the baby is through the USG ultrasonography or through the Doppler ultrasonography. So USG is one of the most commonly used procedures in obstetrics, especially as you can see this USG. There are so many types of probes are using. This is the most commonly two types of probe that we are commonly using is curvilinear probe and this endocavity probe. So this curvilinear probe we are using for abdominal examination, and this endocavity we are using for transvaginal examination. So this probe contains a picoelectric crystal. So these crystals, when an electric energy is applied, they produce sound waves. So this sound waves is passed through the tissue, and then it gets revert back. And this and the then it is and this then the echo or the echo is received, and it is converted into electrical energy, and it is displaced in the screen. And another thing is this is a non-ionized radiation, so it is safe even for pregnancy. And a coupling gel, you can see this there is a gel is applied before using this probe. So this gel helps to prevent the air in between this maternal surface and the probe. So the basic principles of USG contains this echogenicity. That is, the echo is a sound wave is passed and the sound wave reflects back, and this principle is using. So if it is there is water or a fluid is there, so the sound waves get absorbed in that fluid. So there will not be any echo, or there will not be any echo. So it will be applied as black on the screen. If there is a hyperechoic substance, that is, if the sound waves are reflected, more sound waves are reflected back, then it will be appear as white on the screen. So this is the basic principle. The basic principle, black and white, the color difference makes the helps to make the diagnosis. And also the frequency. If in this curvilinear probe, this is we are using on the abdominal surface, so that it had to pass through the muscles, the skin, the fat tissue, etc. So for more there's more surfaces are there, we are using a low frequency mode, so that the sound waves may pass more deeper. If high frequency, especially in transvaginal examination, we use a high frequency, so that more clear images we will get. So mainly in first trimester, the main we will assess the pregnancy, that is, if the pregnancy is present inside the uterus or not. That is the first aim of diagnose first aim of a USG. The second thing is to rule out an ectopic pregnancy, and then we will see whether the gestational sac, if it is 5 weeks, we can see a gestational sac inside the uterus. I will show you. This is a gestational sac, and this is the uterus. You can see this is a uterus, and this is the gestational sac inside the uterus, and this is a yolk sac, and this is the fetal pole. So by 5 weeks, you can see a gestational sac inside the uterus. 5.5, 5.5, 6, 6.5, like that. 5 weeks gestational sac, 5.5 weeks you can see a yolk sac, 6 weeks you can see an embryo. In 6.5 you can see this fetal heart rate. You can see small flickering like this. So if a gestational, someone asks a question. Dr. Jasul, Anandita is asking a question.
Yeah, questions we can
Okay,
address last.
Okay,
You can
okay.
continue.
Okay. The first can also we can assess the number of pregnancy, whether there is a multiple pregnancy like that. We can see if there's two gestational sacs are seen inside the uterus, then we can say that there's a multiple pregnancy. And another thing is the dating, that if heartbeat is seen, or if fetal pole is seen, we can say that it's about 6 or 6.5 weeks, like that we can say. So dating of pregnancy is also is assessed in the first scan. So there are so many abnormalities we can see in the first scan. Some is like ectopic pregnancy. I had already mentioned the pregnancy which is outside the uterus or outside the main uterus. There is anembryonic pregnancy. Anembryonic pregnancy means this gestational sac will be seen even after 6.5 or even after 7 weeks. There will not be any yolk sac or a fetal pole or a fetal heart rate. This is an embryonic pregnancy. So we can easily diagnose this gestational sac with a diameter more than 16 millimeter. Then also there is no yolk sac or fetal pole. Then it is known as an embryonic pregnancy. Okay. Then missed abortion. So if there is some bleeding, we can see retroperitoneal bleeding. You see, then we can opt for it. Then we can think about a missed abortion. So this is a normal. So this is we can see this gestational sac, and this is a yolk sac, and this is a fetal pole. This image we can see ultrasonographically like this. So in a first USG, these are some of the common terms we can see. MSD, mean sac diameter. I had already mentioned this is a gestational sac, and I am measuring the diameter. That is the mean sac diameter. If mean sac diameter more than 16 millimeter and absence of embryonic pole, there is an empty gestational sac or a blighted ovum or an embryonic pregnancy. These are the common terms we are using. Next, we can see in an USG, a USG report is a CRL, that is crown rump length. So this measurement is taken as crown rump length. This area will develop into future head. So this diameter is measured as crown rump length. So we can see in a report the single viable intrauterine gestation. So in every report, it will be specific, clearly mentioned that intrauterine gestation. If a gynecologist miss an ectopic pregnancy, it is considered as a very bad obstetrician. Like that, it is considered. So abnormal findings are ectopic pregnancy. So this is an image of an ectopic pregnancy. This is a normal uterus, and this we cannot see any inside the endometrium. We cannot see any gestational sac. We can see a gestational sac near to this area. So an embryonic pregnancy we had discussed. And another term we will see in the first trimester or in the early scan is subchorionic hemorrhage. Subchorionic hemorrhage means this is the trophoblastic cells and which may develop into future placenta. So there is some blood is seen on the back side surface of this future developing placenta. So this subchorionic hemorrhage. So there is a chance of threatened abortion is there. In almost 60% of cases, it may usually reabsorb, or the continuation of pregnancy is possible. Like with our Garbhastamana drugs, we can continue the pregnancy. In some cases, there may be a chance of abortion also. So another common finding is of not common, but another type of finding is of hydatiform mole. So this trophoblast, there is this trophoblast develop into placenta. So there is will be an abnormal proliferation of this trophoblast, which may lead to this hydatiform mole. So in such type of cases, then abortion is a must, and serum beta HCG should be monitored for complete evacuation of this hydatiform mole. So, and one of another rare complications also uterine anomaly also we can see in the first trimester scan. So this is uterine didelphys. That is, there is two half of uterus. So sometimes an embryo may attach in a particular horn. So there may be an early preterm labor or even abortion may be a cause. In this is an ultrasound image of this bicoordinate uterus. You can see this gestational sac on one hole. So another thing is in the nowadays it's a common procedure to do an aneuploidy scan in between 11 to 13 weeks. Aneuploidy means there is this test is done to detect whether there is any chromosomal anomaly. So it is usually done between 11 to 13 weeks. So this first time aneuploidy screening help us to detect almost 85% case of Down syndrome. Down syndrome means there's a trisomy 21. That is, there is some defect in the 21st chromosome. Okay. Then we can also easily see the nuchal translucency. Like this is nuchal translucency. That is, there is here you can see this anomaly in the skin fold and neck. So if there are fluid deposit between the skin fold and this neck region, so that this measurement will increase. So in this case, this nuchal translucency is more than 3.5 millimeter. That is, in this case, the nuchal translucency is more than 3.5 millimeter. So then definitely there is a chance of chromosomal anomalies there, or trisomy 21 can be suspected. So nuchal translucency is one of the most observed in most of the cases. In all cases, you had to observe the nuchal translucency. This is a patient case report with nuchal translucency is 5.1 millimeter. They were advised for further screening, and at last they decided to terminate the pregnancy because the baby is having a risk of trisomy 21 or Down syndrome. And the earliest anomaly which is detected is anencephaly. Anencephaly, that is, there is absence of this most of the skull bone and brain hemisphere. This is the most earlierly detected anomaly. By 10th week, we can detect this anomaly. So in Down syndrome patient, another thing they will observe is the nasal bone. That is, if nasal bone, this is the nasal bone. You can see this. This is a nasal bone in a normal patient, and in this case, there is absence of nasal bone. So absence of nasal bone is also an indicator of trisomy 21 or Down syndrome. And then the third scan is done is an anomaly scan, which is commonly done in 16 to 18 weeks. Okay, the first scan is to confirm the pregnancy and also to confirm the position of the pregnancy, whether it is intrauterine or not. The second scan is the aneuploidy scan. Now it is done between 11 to 13 weeks. And the third scan is the anomaly scan between 16 to 18 weeks. In this scan, every part of the body, of the fetal body, is observed, whether four limbs are present or if the head is normal in size or not, whether the head size is increased. Like in hydrocephalus, the head will be much larger, or whether the spine is intact, whether there is any discontinuity or spina bifida is present, like in thorax, whether the heart has four chamber, like that, every part is observed. And even the umbilical cord, whether the umbilical cord contains three vessels, that is two arteries and one vein, and whether there is adequate amniotic fluid is present around the baby. All these things are detailedly evaluated. So in a UST, you can see some common terms, especially in this anomaly scan: BPD, HC, FC, AC. Like certain terms are there. So we will discuss what are these common terms. That is BPD, biparietal diameter. That is, this is the transsexual view of the skull of the baby. So this diameter is the biparietal diameter, and head circumference is also measured to in order to evaluate is there proper growth of the baby is there. Also to exclude there is hydrocephalus or microcephaly. Microcephaly is small head. Hydrocephalus means large head. Femur length, which is the longest one, its length is also measured to assess the fetal growth also. Abdomen circumference, this factor is also assessed to the fetal size is increasing or not. So now you know these terms: BPD, biparietal diameter, head circumference, femur length, abdominal circumference. So these are evaluate the fetal biometric profile. And then we'll go look for fetal environment, whether the placenta is located in the correct place. That is, In this image, you can see the placenta in the upper portion, around the fundus or in the anterior wall or the posterior wall, like that it is evaluated. If the placenta is situated in the low portion or it is a low lying placenta, so as a pregnancy advances, this uterus gets stretched, so there is a chance of bleeding. And also in this third case, you can see the placenta is almost covering the cervical opening, so there is a less chance for normal vaginal delivery. Okay. Another thing is this placenta accreta, increta, percreta. That is, if the placenta is attaching more deeper into the muscular tissue of the uterus, then it is placenta increta. Like if it pierces even outside the uterus, then it is placenta. It's like percreta. So we are assessing the placenta size, location, etc. Another thing is amniotic fluid. The fluid around the baby is the amniotic fluid. We are looking for whether there is oligohydramnios, that is whether the fluid is less, or polyhydramnios, whether the fluid is more. All these are abnormal conditions. So you had to check the fetal environment also, fetal biometry also. So by the ultrasound screening, if it is more given importance to maternal age. If the lady of age greater than 35 years, the screening test is important, or history of repeated abortion. If both the partners have family history of any congenital anomaly or a mental retarded, or a previous baby with any congenital anomaly, these patients had to do a thorough screening for this aneuploidy or even for this anomaly scan. So in a screening, we first do an ultrasonographic evaluation. So in an ultrasonographic evaluation, we saw that there is an increased nuchal translucency or nasal bone is absent. So we can think that there is some sort of anomalies there. So we will do some biochemical test. So some serum or blood test. Like in first trimester, we will do a papa test, that is pregnancy associated plasma protein A or beta HCG. These are the two markers. Like this pregnancy associated plasma protein A is secreted from this trophoblast. This trophoblast is further proliferated into two types, cyto and syncytial trophoblast. So these syncytial trophoblasts secreted this pregnancy associated plasma protein A. So when the level of pregnancy associated plasma protein A is low, then there is an increased chance of this anomaly is there. Another is serum beta HCG. Serum beta HCG, if in a Down syndrome or in a trisomy 21, it is almost 2.5 times more, like 2.5 times more, multiples of median. So then also we can see that these two markers are abnormal. So there is a more chance of abnormality to the fetus. So in a second trimester, that is after this 16 to 18 weeks, we will do a triple test. Triple test means similar like that. That's like it is easily remembered by A, alpha fetoprotein, B, serum beta HCG, serum beta HCG, and estradiol. These are the triple marker. The quadruple marker means the same triple marker plus one more inhibin. Okay, is it clear? Triple marker is serum alpha fetoprotein, A for alpha fetoprotein, B serum beta HCG, and estradiol. Quadruple plus one more inhibin. So if there is any neural tube defect, neural tube means if there is any developmental defect in the brain as well as in the spinal cord, that is neural tube defect. In such case, the alpha fetoprotein level will be high, the serum beta HCG, the other three markers will be normal, or inhibin bay is not applicable. In anencephaly also same, the alpha fetoprotein level will be high. In Down syndrome, the alpha fetoprotein and the serum estradiol will be normal, but serum beta HCG and inhibin A is high. in trisomy 18. That is trisomy 21 means there is there is some abnormality in the chromosome number 21. That is trisomy 21. 18 means there is some abnormality in the chromosome number 18. So we by the screening test we found to know that there is some abnormality. So that there is that screening test only. So we had to confirm our diagnosis. We had to confirm that this baby is having some congenital anomaly. We had to confirm our diagnosis. For that we use some invasive diagnostic methods. Okay, some of the invasive diagnostic methods like chorionic villi sampling, amniosynthesis, and chordosynthesis. These are the invasive diagnostic methods. So we will deal one by one. One is amniosynthesis. Amniosynthesis means in which there's amnio. Amnio means amniotic fluid. We are taking the amniotic fluid and we are examining. So the amniosynthesis means under the ultrasound guidance, by the ultrasound guidance, a needle, a long needle is inserted to the maternal surface, maternal skin, maternal tissues, in the of cover passing the uterine musculature, and then it reaches the amniotic sac. Then 10 to 20 ml of this amniotic fluid is collected. So we had to insert it properly. That is why we are using an ultrasound guidance. So 20 ml is taken and that is evaluated. For cytological study, we are sending that. So this amniosynthesis process, it should be done best between 14 to 20 weeks. So by this we can assess the congenital anomaly like 21, 18, etc. And also some of the risk for this amniosynthesis is like that there may be a risk for the accidental needle penetration to the baby, or there is 1 to 2% chance of fetal loss itself. Okay. Another is chordosynthesis. Cord means umbilical cord. We are piercing the umbilical cord and we are collecting blood from the umbilical cord. This is also a USG guided procedure, carefully inserting the needle into the umbilical cord, almost situated within 2 to 3 centimeter near to placenta, and blood of 0.5 to 2 ml is collected. And this test is especially done to rule out fetal blood related disorders like fetal hemolytic disease, fetal isoimmunization, fetal thrombocytopenia, or even fetal infection. This is best done between 18 to 20 weeks. You may get correct report during. In this case also there may be complication like fetal blood loss or accidental insertion of this needle to the baby, or even cord hematoma. Another is chorionic villi sampling. This is to be done between 10 to 13 weeks. So by inserting a cuscus bivalve speculum through vaginal portion, a catheter is inserted under ultrasonographic guidance. This chorionic villi, that is the form of placenta, that this chorionic villi develop into placenta. So from the chorionic villi, the sample is taken and it is assessed for the fetal DNA. So by all these tests, we are taking the fetal cells, especially for the DNA analysis. We can use it either in two types. Either this FISH test, like fluorescence in situ hybridization, like that. In that case, if I am suspecting that whether this baby is having a trisomy 21, so I am telling to test this specific gene. For that, we are using this FISH test. In the second case, I don't have any idea about which gene is affected. So I am suggesting a karyotyping. Karyotyping assesses all part of this genes. So if you have any specific idea of this particular gene is affected, then you will suggest a FISH test. Okay, so in short, first you had to screen a high risk pregnancy, especially mother greater than 35 years old, or with a family history of any congenital anomaly, or even a previous pregnancy with congenital anomaly. You had to screen those patients, and you had to do a detailed ultrasonographic evaluation. Or in some patients, by chance or in by an ultrasonographic evaluation, you happen to see anomaly, you do a detailed ultrasonographic evaluation. Nowadays, there are more fetal-maternal specialists who do a thorough investigations on this congenital anomalies, etc. Then you will do a biochemical test like a triple test, quadruple test, etc. Then after the screening test, you will do a confirmatory test by an invasive test, like invasive tests like this chordomyosynthesis, aminosynthesis, etc. Then after that, you will do a karyotyping, either karyotyping or a FISH test. Most of the couple who have this, especially I had mentioned that case who with neural tube defect with nuchal translucency more than 5, that patient came to me for a second opinion. In that patient, they were advised that with biochemical markers also there is a high risk of trisomy 21, and that patient were advised an invasive test by the infertility center. So such patients, some patients may go further with the invasive test, but some patients may think that if there is a high risk of this congenital anomaly, then they opt for a then they opt for an abortion. Some patients, if they're precious baby, they will go further for an invasive test, and whether they will confirm whether this baby is healthy or not, then they will decide whether to continue the pregnancy or not. So now we will do it's an oral glucose tolerance test. It is done especially in 24 to 28 weeks. Even if a lady in her first trimester, if she is non-diabetic, there is a chance of lady to become diabetic in 24 to 28 weeks. So in such type of patient, we had to screen all patients. So 75 gram of glucose is given after 8 hours of fasting. Then first fasting blood sugar is measured. Then after 1 hour, another sample of blood is taken. Then after 2 hours, if the value is above than normal, then the patient is considered to be diabetic, and she had to advise for certain specific diet. After even after that, her insulin level is much high, then she may give insulin. Normally, it was glucose challenge test, that is 50-gram glucose was given, or glucose tolerance test, 100-gram glucose was given. Now it is oral glucose tolerance test with 75-gram glucose is given. This is done the time you had to be clear within 24 to 28 weeks. Other complication, which is other complication, other investigation especially, is hypertension is one of the higher risk in pregnancy. That is, it is considered among the dangerous triad. That is hypertension, other thing is bleeding disorder, and the third is infection. So these are the three dangerous triad in a pregnancy. So every month the woman is checked for her BP. So usually in first trimester the BP just fall a little bit. After 20 weeks there will be an increase in the BP level. So in a gestational hypertension there may be an increase in BP without proteinuria. But in preeclampsia means there is increase in BP with proteinuria, and also there is edema in the body, there is a headache, and also eye related some pain in the back of the eye. Their patient may have pain. In such type of patient, we had to further evaluate, and we had to manage her BP. So even after delivery also, it takes 12 weeks for the hypertension to be controlled. Then it is a third trimester scan. The third trimester scan is mainly assess to the fetal growth and well-being, whether there is any intrauterine growth retardation. That is, intrauterine growth retardation means the normal fetal growth is assessed. If it deviates from the normal standard level, if it deviates less, that is baby weight is much less, then there is a risk of intrauterine growth retardation or IUGR, or there may be also a risk for intrauterine death also. And also it is done to confirm the presentation of the baby, whether it is a cephalic presentation or breech presentation. Cephalic presentation means head down, that is head is in the lower portion of the uterus so that there is a chance for normal vaginal delivery. In breech presentation, there is a less chance for normal vaginal delivery. So in late pregnancy, another investigation or diagnosis, non-stress test, NST, which is commonly done. In this is one unit to measure the fetal heart rate, and this ladies and this is a measure with this measures the fetal movement. If a baby moves, it is the lady is advised to push the button like the certain pen, no, like that the lady had to push. It is observed for almost 20 to 60 minutes. If the basic logic behind is that if a baby moves or a baby kicks, her heart or his or her heart rate may increase 15 beats. After 15 seconds, it comes to back to normal. So if it shows that it is a reactive NST or the baby is normal. So if the baby is hypoxic or if the baby has less oxygen supply, then this normal increase and decrease is not seen. So we can think that the baby is having hypoxia. We had to manage immediately. So NST is done for 20 to 60 minutes. So in that fetal heart rate and fetal movement are assessed. This is a third trimester scan. In this, you can see this intrauterine fetus with cephalic presentation. The fetal biometry correspond to average. Mainly the presentation is mentioned. The fetal weight and fetal growth is assessed. So here ends the detailed obstetrical investigations or examination that we do in Dr. Jasul. Hello.
Yeah.
Shall I continue with the second part?
Yeah, sure.
Okay. Now, if we are moving to the gynecological investigations. So, in this gynecological investigations, we can see that we had to do a detailed history. That is much important in gynec. In every gynec patients, you had to do a detailed history with detailed menstrual history, last menstrual period, pre-menstrual period. You had to assess 3 consecutive menstrual periods so that you can assess the regularity of the cycle and also the cycle length. Cycle length should also be measured, that is whether it is 28 days or how many days the bleeding is. And if the patient is sexually active, sexual history also important, especially in infertility patients. You had to ask for the sexual history also. I think there is mixing of slides is there. Sorry for the trouble. I want to add 2 more points in the obstetrical investigations. So one more thing is 3D scan, 3D or 4D scan. It is now an advanced type of scan. It is especially done for the to assess the cleft lip or cleft palate, that it can be easily seen in the 3D or 4D scan. Doppler scanning is also done in the last trimester. It assesses the normal flow of blood through the umbilical artery or uterine artery, which is essential to understand whether